Awesome. Thank you so much for having us. We were really excited to learn about your Spark Center and see the different kinds of talks you have posted online. Hey Young and I are both medical sociologists working in an interdisciplinary department. So we hang out with anthropologists and psychologists and demographers, but we're both trained in medical sociology and specifically in qualitative methods. And then we both study different aspects of the healthcare system. So Hey Young tends to look at maternal health, and I tend to look at end of life stuff. So we just started knocking heads about some of these issues around racialized injustice in health and healthcare, and then thinking about how qualitative methods intersects. So this has become a topic we like to talk about at the drop of a hat, and we're happy when anyone wants to join us in that conversation. So this is actually the second in a series of papers. We wrote one that was sort of about, it was a little bit more of a theory paper, and I think of this one as more of a methods paper. And so we just have a few slides here to kind of cover some of the things that were in the talk, and then we are hoping to open it up for discussion with the group. So when we think about understanding health and equity, right, like it's probably everyone here understands, like there's been a real increase in attention to health equity and especially multidisciplinary attention on health disparities. So this is definitely a good thing. The place that we've been really thinking about is, and this is maybe, I'm not really sure how Canada fits in with this. We would welcome your comments on this, but thinking about a US centric agenda compared to like a European one. In the US research agendas, we see a very heavy emphasis on like demographic inquiries of race and health, right? So race is a characteristic of individuals, it's a predictor of health outcomes, and that whole conceptualization kind of lends itself to very quantitative, big data, statistical kind of analyses, which give you certain kinds of perspectives and leave other ones out. So we feel like that perspective has dominated a lot of research around health inequality for a long time. And one of the things that gets left out is racism as a process, and also how racism gets embedded into our social structure. So structural racism. And we feel like there's really missed opportunities to examine the context, the lived experience, interactional processes, all these different kinds of things that shape the relationship between race and health in ways that go beyond sort of this demographic predictor model. So these are some of the people that we're building off of. We are certainly not alone in being kind of having this on our minds. And so this first bullet is just a few examples of papers that we think are great if you're looking for work kind of in this vein. Growing empirical research about racialization. These all appeared in the Journal of Health and Social Behavior just in the last year, but things like racialized use of time, racism-related vigilance and allostatic load, racialized differences in obstetric induction rates. So great papers. All of those are very quantitative, but also trying to look at racialization as a process and move beyond this race as just belonging to one person kind of model. Then we came upon this paper by Brown and Homan last year, also in the Journal of Health and Social Behavior. And I think that might have been like the spark in a lot of ways for this paper, because they focus on structural racism. In a lot of ways, we are very much aligned with them. They're thinking about how US states are racializing institutional actors, shaping individual health. So that's very exciting to think about states as racializing actors instead of just individuals having a demographic characteristic of race, right? But they make this point, and this comes from another article, but that less than 1% of studies on race and health have empirically examined the health consequences of structural racism, which is kind of mind-boggling, right? I didn't think it was going to be that low. I think Hey Young and I were both like, that's really bad, just 1%. And from there, they kind of say like, well, this whole idea of racialization is very slippery. It might even just be a latent concept that we can't observe. And this is where Hey Young and I kind of sat up and said, well, we don't think that that's the whole story, that we think racialization and structural racism are observable, but you might not be getting at it with statistical methods and big demographic approaches, right? So that we thought qualitative approaches would show us how racialization is manifest and available as an empirical topic of study. And so we followed up that they did this search on articles and found that 1% of studies looked at structural racism. We were like, well, how many of those are qualitative? And we went to sociological abstracts from 2018 to 2023. We found like almost 1,500 papers that were looking at structural racism in health. And when we added qualitative in, it plummeted to like 37 papers. So we were like, wow, if it's 1% looking at structural racism, it's really like 2% of that are even using qualitative. So this is the area that we're swimming around in. So I'll turn it over to Hey Young.
So, as Karen has said, given one, that there's just very little focus on structural racism, and two, the fact that we really often think about race in terms of individual characteristics, unsurprisingly, the individual is centered in a lot of the research that's been done. And so, because of that, deficit approaches and deficit explanations tend to prevail. And so, why does that happen? One part of it is the fact that sort of normative standards of good health and good patients have been derived from a white, middle, and upper class patient population. And so, what we see is that that normative standard, which in many ways is a proxy for white, middle, and upper class patients, then is compared to other groups. And then those other groups are seen as having deficits, lacking, explanations for highly medicalized end of life experiences for Black patients, or explanations for lack of compliance, or explanations around distrust in medicine for certain racialized and marginalized groups are often explained in terms of this deficit that they are lacking, that certain individuals in certain communities are lacking certain resources or education. And what then happens is that we ignore the deficits present in the system. And so, to kind of reiterate what Karen said, there have been other people doing great research in this area. And we just want to emphasize that again, that we are joining the call for additional research on structural racism and racialization as a process. And these are just some examples of areas where we're seeing this push that in many ways, the relationship between race and health has been well established in the literature, but then at the same time, we're only scratching the surface because we're only seeing it in certain types of ways. And so, Hardiman and colleagues are really pushing for more of this multidisciplinary approach to include multiple perspectives to really think about health equity, and of course, qualitative methods too. We see with Garrett and Dicoteau the concept of data citizenship, and just even I think sometimes that data, we sort of black box it and we assume, okay, now these are trends, but recognizing that even who gets measured quantitatively, who has that data is also deeply stratified and can be quite racialized. And there was an article actually by Rose Archer that I just came across from Sociology of Health and Illness that was published this year that speaks to some of this, where a Black community in Florida is actually maternity care desert, but they're not identified as one. And so then they don't get the resources. And so it's just a great example if anyone's interested in that area. And same with Friel and colleagues, just, trying to get at structural racism, increasingly capitalizing on qualitative interviews and trying to pull just different methodological approaches, right, to try to understand these processes and how they then impact social structures and institutions.
So Hey Young and I we like to work on doulas, right? So we have data on death doulas and birth doulas, and that's like one example of a space that we're kind of hanging out in and thinking about. But I feel like this is one of those topics, like once I started thinking about it, I saw opportunities everywhere for it. So even just in the course of teaching like a social determinants of health class to my public health undergrads, right? And you think about those multi-level like social ecological models, just even like the most basic kind of health disparity stuff. Individuals are nested in larger macro systems. And I just started thinking about at every level of that, how there seems like there's opportunities to peel things off and like learn more, right? So I was thinking about some geographic variation studies, right? How, well, like Hey Young's example right there of a maternity care desert, right? We have those with end of life care too, like how the availability of resources gets kind of baked in at the county level, at the state level, at the local level. And then, I mean, in the end of life field where I am, we like to just say, like, well, people just didn't choose hospice. We just individualize that and then be like, oh, and then there's a racial gradient in who chooses hospice. And you're like, well, except that there's nothing available in their environment, right? And so how do we think about racialization being built into an environment, becoming part of the social structure? Like longitudinal and historical studies, I was thinking also about even just using the example of how gendered things get baked into our healthcare. Like we know a lot about that, right? And medical gaslighting. And so we see that gendered stuff gets built into our research. We like to rely on male animals and male cells and male bodies, and then assume that women are going to be just the same, right? And that anything else is bikini medicine. And then that gets baked into our research and our drug approvals and our medical education. And it just creates this pipeline that just reinforces itself. That's a case of gender, but like why can we not be looking at race in some of those ways too? With historical studies, I feel like some of the best stuff I've seen on racialization on end of life comes from historians, but thinking like longitudinally about how these processes unfold, I think super cool, lots of opportunities. Social network studies, like, right, tend to be really quantitative, but like, can we think about the same sort of thing? Like, how are things being built into social structures, into communities, into cultures? And so that things that become choices or behaviors or perspectives are not just living with the individual. And of course, we have these really wonderful emergent racialized organization studies. Victor Ray, Hey Young, and I love that stuff. Hey Young's book is just fantastic, an in-depth dive on like healthcare organizations and how doctors are conflicted because they're dealing with these different kinds of pressures from organizations and what they should do. So just to do a quick illustration, like how I feel like I see this everywhere once I started thinking about it. All right. So really our focus is on thinking about how qualitative methods can come into play here and the contributions that can be made to examine these issues and not to be just in competition or putting down the demographic approaches, but I think really to push back on Brown and Homan about whether or not these things are actually latent. I think that's an empirical question. Is it latent? Is it observable? And I think it's too soon to call it latent because we have not deployed all of the kind of qualitative and other interdisciplinary perspectives that we could bring to bear on these questions. So I say premature to call it latent. And what happens when we think about instead of a deficit model, like Hey Young was explaining, the ways that whiteness is built, promoted, sustained over time, and how racialization unfolds at structural levels within the context of health.
And so just our final thoughts, ultimately our main argument is the need for more qualitative research just to add to this robust scholarship on racialized health and equity. And so as we already said, sociological studies have long been dominated by more demographic approaches, the centering of the individual. And so with that kind of these deficit explanations and really this oversimplification of the relationship between race and health. And so certain things are just not being captured. And so then on the flip side, racialization is really critical to understand racialized health and justice. And just as Karen mentioned, these examples of what we can study. And we know that in other areas of sociology, at least like urban ethnography, we know some of these things have been tackled from a qualitative approach. And so it's more just why not bring that into the context of health? And in our case, within to medical sociology. And so really, once again, just kind of plugging how qualitative methods, while vastly underused in this area, are really well suited, right, to think about racialization, to understand and study it. And another example is just studying how non-white groups work within these racialized systems. And we just see really rich opportunity for more research in this area with these qualitative approaches.
So thank you so much. We thought it would be good to like keep the paper's not super complicated, so we thought it would be a good thing to invite discussion, and we would love to hear what people are kind of thinking about on this topic too from your side.
All right. So the floor is open. Feel free to unmute and raise a question. While people are thinking, I will start out, which is that so at Spark, we've been talking with an organization in Canada that's really interested in looking at Islamophobia in healthcare. And one of the things that we ran into right away was intersectionality and how on earth you begin to differentiate between discrimination that is experienced across multiple aspects of identity without going straight into quantification and forcing demographic classification that is often inappropriate and uncomfortable and all kinds of issues. And so, we came to something, but it was relatively unsatisfying. And I'm curious how you think about the complexity of intersectionality in these contexts.
Do you want to jump on that, Hayoung?
Sure. So I have found intersectionality, I don't want to say easier to address, but something that I think is just coming up in qualitative methods, or maybe the way I approach it in a way where I haven't seen it as an obstacle, because I think in a lot of ways, I'm not categorizing individuals, right, into certain identity groups to then compare them or to certain characteristics, and instead thinking about their experiences like on the ground. Like I can think about the birth workers that I have been interviewing, where many of them have multiple marginalized identities that they are navigating while trying to do birth work successfully in the US. And so I haven't found it to be an obstacle as much as something that really opens up more theorizing and much more interesting analysis about how racialized inequity emerges within childbirth, but then also within this professional space for this group as well. I don't know if that answers the question, but I have never seen it in that quite that way. But I think it may be the nature of the types of questions I'm asking, and partially this more qualitative approach I've taken.
Yeah, my sense is that a lot of what you're doing is very much exploratory in terms of being able to define all the dimensions of this vast space. And of course, when you get community engaged research with a very specific questions, you're kind of stuck with it. And that's where it starts to get into some of the awkwardness of having to break down intersectionality. When I agree with you, I think that the best approach is to treat people as people and to look at individual circumstances rather than trying to sort of pin down a range of demographics and define them as an intersection of those.
So how did you deal? So what happened with I'm curious now with the Islamophobia study
So
and
it hasn't
community
come,
partners. That's a really important point.
the study hasn't come together yet, but in building out the research plan, it became about really asking people to self-identify in whatever ways they felt comfortable with, and then dealing with the mess of that in the analysis phase. And we did sort of a mix of, part of the proposal is sort of in-depth qualitative work with people, and then part is a large national survey so that we could try to get, and with oversampling, so that we could try to get some sort of concrete numbers around Islamophobia in healthcare. But what we really wanted to do was actually be able to tell the broader story of people's experiences, to actually bring in the narrative detail. That by far that seemed much more important. But in order to be able to sort of move things politically, you also need a number.
For sure. For sure. That's such an important point.
Faith.
Hi. Just on the topic of religion, I've noticed that some healthcare institutions are religiously affiliated. Do you guys have any insight on how that may affect patient care?
Yes, well, just in the context of childbirth and reproductive health, certain religiously affiliated organizations do not allow for certain procedures to happen in their hospital. So yes, there are some restrictions, at least in the context of maternal and perinatal health. I can say there are certain procedures that aren't allowed in certain types of institutions when it comes to kind of reproduction. And I don't know if Karen has seen things around end of life care as well.
I don't think I've seen it as much like built into like formalized in the healthcare organizations, but I feel like religion is something that gets like thrown out a lot in service of, trying to explain individual decisions in terms of making something an individual thing and calling attention away from the structural environment and the care that they might be receiving. So I think that can be, it's a very rich, sticky kind of resource for some of these processes.
Thank you.
Marina.
Hello, I had a question more about the research ethics involved in, well, I guess qualitative and quantitative, but just keeping in mind kind of qualitative, interview stuff like that can take a lot of time and sometimes involves location. I guess I was wondering kind of how you approach the ethics of, I always think of like shared value. And there has been more increase of kind of having multiple researchers, like maybe from the local cultural context, to try to help rectify some of like the authenticity issues. But I noticed there is kind of a lack of shared benefits to the participants. Like, for example, like at McMaster, I could do a psych study and get like $25 from that. But then when kind of working with what's kind of deemed as like vulnerable populations, there's a lot of ethics concerns about like monetary value and different like almost like payment options for someone's time and someone's like travel to get to maybe some of these qualitative methods. I don't know if you guys have any insights of kind of how to approach it more ethically.
I don't care. And if you want to go first.
And you look like you're going to talk.
I think this is an ongoing issue, and I think it's something that I think about a lot. In my instance, the populations to this point that I have interviewed, when I did my hospital study, it was trainees and doctors, and it was just in their workplace. But then now with the maternal health study I've been doing, it was cold emails to birth workers, OBs, midwives via their professional websites and their emails. And so everyone was equipped with the resources needed to do a Zoom interview. And so I did Zoom interviews for everyone and then sent folks gift cards afterwards. And so the transportation and some of those very real issues were not as much an issue in this case. But I think the downside to that, right, is that there is a population that's not being sampled, right? It's only folks who have these professional websites and have these emails and who are able to, do a Zoom call with me. So I think that's one part from your question that I think is absolutely an ethical issue. And I know with IRB, it's very complicated when working with populations where the monetary compensation even is put into question, where if it's too much money, they're saying, there can be coercion. But on the flip side, I also think people are giving your time and we should give them, financial compensation for it. And I don't have an answer to that, honestly. It's something I've been thinking about a lot, though. But then I think on the flip side, there's another part to your question around who actually benefits from the research being done. And I think that is a sort of ongoing ethical dilemma as well. My hope with at least the birth workers that I've interviewed, I've majority interviewed birth workers who identify as individuals of color. My hope is that there's increase, that this research can translate to really thinking about the pressure and lack of compensation that we are placing on these birth workers in the United States, especially as there's a rollout of Medicaid trials around coverage for doulas and really emphasizing in a lot of ways the need for doulas to improve maternal health disparities in the US. And so I guess my hope is that to shed light on that and to make some impact, but I think this is the ongoing dilemma that sometimes who we're studying, how that positively impacts them in the long run remains uncertain.
And just, I guess what I would add on to that is, like, in some ways, I think some of the reasons it remains uncertain has to do with these very issues about how research is racialized and gendered and reinforces a lot of these like default perspectives about where the value is. And I mean, in my end of life research, I spent a lot of time going to people. Like I would show up in their living rooms and interview them, and that was amazing and really productive. But then there were different times in my like career time that I just couldn't do that. And so there was a time where I had to, you know, I took on administrative roles in my department or whatever. And then like I could not be gone driving all over creation, going to people's houses. And it was really bad for my research. So I think those are tricky things to get out of. And then also kind of having sat on a lot of like for NIH in the US review panels for grants, I think it should not be assumed that large quantitative studies don't have their own ethical problems. I think sometimes we treat that as like those are fine, and if you give someone a gift card, that's totally, you've covered your ethics, and those ethics just remain kind of in a black box of their own. And then it's easy to say like, well, did you cover someone's like time and bus fare to come participate in your study? So I think there's ways to kind of flip that conversation around and be asking where ethics resides and where these reinforcement structures come into play.
Thank you.
I'm curious in your broader research or in what you've seen in others, if there's been any exploration of what may or may not look different within healthcare institutions that are owned by people of color. Or so I'm thinking, I worked with farm worker clinics for quite a long time that were often directly the governance of the institution was farm workers, not necessarily the doctors, but certainly the governance structure. And I know there are a number of Black owned hospitals in like Baltimore and some of these cities. So I'm curious if anyone has looked at, because there's so many structures to this. There's sort of what the financial um, profiles are in terms of the incentives on hospitals, which are probably consistent, at least within a state, or maybe somewhat consistent. Then there's the actual sort of organizational level, and then there's the individual healthcare players level. So I'm curious about trying to disaggregate that some way, in some way. This might be my quantitative side coming out.
Well, I'll grab this one if that's okay. So in my days before I came to Colorado, I worked on a series of video vignette factorial experiments, very most like leading quantitative in Boston. And we were using experimental design to try to disaggregate or get, you know, unconfounded estimates of how patient characteristics, provider characteristics, and system characteristics affected diagnostic and treatment decisions that doctors came up with, right? So we would show them, we had these video vignettes. You would go into a doctor's office, open the laptop, someone would show them this patient vignette, and they were standardized. So they were all actors reading the exact same script across all the vignettes, and we would just hire actors that were different combinations of gender, race, and age, and then kind of see what the doctors thought was going on and what treatment they would do. And so, for example, this is a way we could really disentangle how women were getting missed for heart attacks, right? And tease out what led to those differences. But one thing that just blew my mind was how, you know, we like to talk about these things as being happening at the individual level. It really matters who that patient is that comes in the room. But as we added layers into the study, all those more macro levels mattered more than what the patient characteristics mattered. And so it mattered who the physician was, what were they, male or female, how long had they been out of school. We saw differences in how much they used like clinical guidelines and online electronic resources for making decisions. But then when we nested those in terms of international systems, comparing the US and the UK and the Germany, then those were the biggest results by far. It completely dwarfed all the other results. And so I think that's not exactly getting at like Black owned healthcare and things, but I think the idea that the system you're treated in matters a ton. And it's very easy to kind of blow by that, I think, when we have these deficit models.
And maybe that's a way in, if you're willing to talk a bit more about your broader work around the sort of financialization of healthcare and the nature of these pressures within systems, and how presumably that's at least part of the story of why there might be a country level difference.
Mm-hmm.
Yeah, so in my book, so I should first just say it's a prestigious academic medical center. It's well resourced. But I think there are interesting pressures and dilemmas there because, on the one hand, where it is allows for patients who are well resourced to access care, but at the same time, the role of academic medical centers increasingly in the United States are also that many of them provide sort of safety net care. They also see a lot of under-resourced patients as well. So there's sort of this interesting mix of the patient population. And in my case, I can only speak to the perspective of physicians and physician trainees and the pressures they were experiencing, but absolutely the financialization was so prominent. Which is funny because in interviews, when you're interviewing them, they're all like, I don't think about money and we don't think about money and like we don't think about cost of care, which is actually part of the problem. But then on the flip side, being able to do ethnography and participant observation on the ground, which is another plug to be able to do this, was that they were thinking about costs every single day. And they were reminded of costs every single day by case management and or by the attending or senior attendings or senior residents of just, we need to discharge this patient. We need to push certain things through. And just, it was always, of course, a part of it is around patient well-being. Absolutely. But there is just this financial pressure that really pushes people through. And so I think that's absolutely there. But I guess maybe one thing that I would plug for increased research is the notion of how organizations themselves reproduce inequity because of how they are created. And I think the policies embedded in healthcare systems are going to be shaped in part by what you said in terms of who owns them. I haven't seen any studies around that, but I think one hand, it would be really interesting to look at a Black-owned hospital versus one that's maybe owned by white individuals, but also thinking about the institutions in terms of who they're serving. And so institutions that have high minority patient populations versus institutions with low minority populations are likely going to have different pressures, even around financialization, that impact patient outcomes, which very much pulls from Victor Ray's like theory of racialized organizations. And I think there's just so much room for study with that sort of perspective. And even in my work, some of the trainees were rotating primarily at my main hospital, but they also were at a county level hospital that was part of the academic medical center that I was not able to gain access to. But there were clear differences in terms of the types of dilemmas they were facing. Based on the institution they were in, where they had less oversight, like they had less teamwork happening, but on the flip side, as trainees, they had almost complete control of types of care decisions. And I think that alone can be controversial. Like, I think there can be advantages to having that sort of autonomy, and then, of course, disadvantages around patient care too for trainees. I don't know if that fully answers, but I think there's so much room, bottom line, for more organizational perspectives around how processes of financialization, how processes of inequity within health are created.
Other questions or comments? Okay, not hearing anyone. I have another one. I always have another one. Part of what you really highlighted was the sheer volume of undone research in this space. And for graduate students and new professors, that's obviously a real opportunity. I'm curious when you think about, and I know you're not experts on Canadian healthcare, but when you think about what you're doing and people who are really interested in medical sociology here in Canada, are there things that you would want to plug for us to consider or look at?
Well, can I come back with a question? Like, because I think that's a
Sure.
really interesting kind of thing. So we at different points, like earlier before this paper came out, and we were in discussion with some European colleagues about, how this would look in their context. And the whole conversation was really different, right? It was almost like we're in a post-racial environment, and Hey Young and I didn't really totally buy that. And so I don't know if you have a sense of like where Canada fits in that kind of international perspective about these issues. Because I get the feeling that I feel like the US kind of anchors this end of being like races belongs to individuals. We're very quantitative, we're very big data, demographic, demography is our field. And then I think there's a spectrum with a lot of different variation. And I get the sense that I don't know if Canada, if you see yourselves as like closer to Europe on that sense, or if what you have in common with the US in terms of where you are in these issues.
Feel free, anyone, to jump in. I'm a still relatively new immigrant from the States, so my perspective is
Okay.
shaped by some of that. I mean, what I'll say is, the similarity to Europe is that at least for sort of basic healthcare, it's covered under a single payer system. So obviously that carries some commonality. I would say in Canada, the Truth and Reconciliation process around Canada's treatment of Indigenous people has really raised a lot of awareness. But I'm not convinced, and I would love to hear from others who have a broader perspective and a longer term perspective of this. I don't see a lot of um, I don't see a lot of that sort of filtering into individual hospital level kinds of analyses. But I'm also looking at it only from the sort of applied perspective and talking to people in hospitals. I haven't actually gone through the papers and seen sort of what's come out. Does anyone else know more about kind of what study of racialization within Canadian healthcare systems looks like?
I couldn't address that, but I noticed a gap within the healthcare system in addressing that. If maybe I could bring that up. It doesn't really answer that half, but I was doing more research about environmental racism in Canada, which heavily connects to the health of Indigenous and other racialized communities in Canada, and came across that in specifically dentistry and in oral health, it's like severely missing really any level of research into like the racist health consequences. And I think that kind of connects to hospitals because at least this isn't through research, but I've just kind of heard a lot of maybe family doctors and other type of doctors kind of refer you to oral, like dental health relating to a lot of mouth related health outcomes. So there seems to be a gap of actually dentistry learning about the racialized side and then them being the referred to source, if that makes any sense.
Claire, you have your hand raised?
Yeah, and I apologize, folks. I missed the first half. I just got in, and if I'm saying things that are already said, just let me know. That's all good. So I'm a registered midwife in Ontario, and I've been born and raised in Ontario, so I have a little bit of background here. I think one of the things that complicates the matter in Canada is not only are we this concept of single payer, but we are a federalist state, and then we have provincial governments that then do kind of what they need to do in each province. So healthcare is actually quite fractured. It is not the same across the provinces, even though there are like five tenets of healthcare that should be seen in every province. So what I think a major challenge for researchers um, when trying to capture the experience of racialized patients or clients is that we're small in numbers. And so across the country, we're small in numbers. And so when we do try and create studies that capture that experience, sometimes we get the basic piece of like, your sample size is too small, therefore your evidence isn't good, which is ridiculous. We also have a big problem with just collecting race-based data, period. Across Canada, which you probably have said out loud, we have real problems with that. And then when we do try and collect it in a cohesive manner, I think there's a lot of issues with identity politics of like who belongs to what demographic, and therefore where do you sit and how do we count that, et cetera, et cetera. And then we layer on the Indigenous experience and we think of OCAP principles and who owns the data. How do we use the data? We're, as a country, saying we support Indigenous researchers, but I've seen it firsthand that we don't. So there's like a complexity, you know, Canada sits in this place of wanting to be progressive, but I just think we're kind of like stuck in the mud. So that's sort of where my my perspective and experiences with it. Thanks.
That's all super interesting. Not sure what I'm gonna think about that some more.
I mean, I think everything that was said very much plugs for more qualitative. Like, I think the reason why, like, even just saying, Claire, you know, our numbers aren't big enough, or all of these things really speaks to this, like, being stuck in such a quantitative perspective, which is what leads to these dilemmas, which are I think it's very common in the US as well. I see so many parallels, like the way you mentioned provinces, the way health is set up in the US. Each state is very different in how certain aspects of the healthcare system are set up, along with race-based data collection. And the Southeast especially does not collect race-based data on health in the United States. So you know, there's so many parallels there. I just think, yes, in the US, race is spoken about more, but it's still done insufficiently, where there are so many groups, definitely Anapeasy groups, that are not captured at all in the data exactly for that same reason, that those numbers aren't there. And I really think there's a plug for more qualitative work, right? Like that, okay, maybe you don't have the numbers, but we can absolutely find narrative explanations of what is happening because we know this inequity is happening. And I think on the one hand, we're talking about in terms of race and health because it's very much a US context in which when we think about stratification and inequity, we think about it through a racialized lens. But I think this is just marginalization, right? In any context, we know stratification happens across the world, maybe with different characteristics that lead to that sort of marginalization and stratification. But I feel like in that sense, this can apply, right, in so many places, because even in these post-racial spaces or places that see themselves as post-racial, like I spent some time in Brazil and it was seen as, you know, they were like, race doesn't exist, but it's like, it absolutely does. And there is this sort of racialization or marginalization that still happens. So there's so much room for it. And I think it just further plugs this discussion, further plugs the need for qualitative health research in Canada to try to get at some of the narrative around unequal outcomes.